We are back. Sam Seder, Emma Vigeland on the Majority Report. Joining us now, Kathy Hempstead. She is a senior policy advisor at the Robert Wood Johnson Foundation. And Kathy, welcome to the program.
Thanks.
We have seen over the course of COVID, via a couple of different relief bills, if you will, the last of which was the American Rescue Act, all sorts of funding for things like a child tax credit for children, expansion of the SNAP program. We saw extended unemployment. We saw expanded unemployment benefits. All of these things now have gone away, despite the fact that we know they had a great impact in reducing poverty writ large, and particularly child poverty in this country, up to 35%, of maybe 40% of child poverty was taken care of by this. One other aspect of this was the expansion of CHIP and Medicaid, which got people onto health insurance. Tell us under what auspices did that CHIP and Medicaid expansion happen, and how?
Sure, that's a good question. When the public health emergency went into effect in January of 2020, it created a bunch of different sort of new health flexibilities, which in many ways, as you kind of alluded to with some of the other things you mentioned, increased equity and really helped people out. I mean, one of the things it did was allow people who were uninsured to get care, testing, treatment for COVID at no cost, and eliminated cost sharing for COVID treatment and ultimately vaccinations, but tests for people who were insured. And then another super important thing that was part of that public health emergency was to create this continuous coverage rule in Medicaid, which didn't exactly expand eligibility, but it eliminated the normal process by which states sort of continuously reassess eligibility, so that some people lose eligibility and are, disenrolled sort of at different points throughout the year. So in a way, it kind of shut the back door sort of for Medicaid so that people could come in, but nobody would be forced to leave. So over the course of the last 2 years, enrollment in Medicaid has grown a lot. And as a result, we have an all-time low uninsurance rate, which is really terrific.
So the COVID relief, the COVID emergency that was declared by, I guess, the CDC, what agency is it? Health and Human Services then has the regulatory ability to waive or to mandate that states no longer make these reassessments, where they basically, the reassessments where they kick people off the rolls of Medicaid because maybe. What are the reasons why they would get kicked off? I mean, they're not poor enough anymore, or what? I mean, walk through us what like the typical ones, because I imagine they change state by state, which is also the part of the problem.
I mean, right? It's there are a million different details to this, going state by state. So I'll just sort of try to give you the big picture, with the context that state eligibility rules for Medicaid are different. Famously, as we know, most states expanded Medicaid eligibility under the ACA to low-income adults, but there's a handful of states that have not. So that's a big eligibility difference.
11, Florida, for one, is not one. I think 900,000 or 600,000 people are going to be thrown off the rolls when in May when this happens. But go ahead.
In Florida, I mean, and that could be like a credible national estimate is that approximately, 15 to 18 million people could lose Medicaid eligibility when this process sort of has run its course. That doesn't mean all those people are going to lose coverage, which is something we can talk about, but it's certainly going to be, extremely disruptive. But during just the status quo ante sort of normal life with Medicaid is, states, and they don't do it all the same way. They do it on different time schedules and using different mechanisms, but states periodically, assess the continued eligibility of people enrolled in the program. And you can lose eligibility because your income increases. I mean, people that are in Medicaid because they have disabilities are much less likely to see their eligibility change, but income-based eligibility can change when people's income goes up. But many times people are disenrolled for sort of procedural or just kind of bureaucratic reasons where they're not truly ineligible, but maybe they move and they don't get a piece of mail, or they, don't respond to something in time. And there is a continued occurrence of something that people call churn, which is sort of like going on and off Medicaid by a population of people that are, that are actually eligible the whole time, or maybe they have a tiny fluctuation in income, but quickly they're back into the into a position of eligibility. So what the public health emergency did, the continuous coverage rule, is it eliminated that churn. It kind of just smoothed that out. So people that came into the program weren't disenrolled at any point during this period. And that's why we've kind of sort of stacked up, enrollment's grown and grown. And now we're going to have this process, starting April 1st, where states, using different approaches and with different goals in mind to a certain extent, are going to start to reassess all that eligibility. And that's when we're going to see, a lot of people lose their eligibility for Medicaid. And some of that will be sort of mistakes, inappropriate, and lots of those folks will come back on, but not all of them. But the goal, certainly the goal of the federal government is to minimize that inappropriate disenrollment.
When states do this, right? I mean, and I don't mean to pick on Florida, but I have no problem picking on Florida. Florida is sort of renowned for having a very difficult unemployment process in which you can claim unemployment. And the theory I have heard, which I think makes a lot of sense, is they don't want to pay out that much. And by slowing the wheels and by, creating obstacles. I mean, we see this in all sorts of like private bureaucracies as well. I mean, you want to claim your insurance, your health insurance. You need to have every form filled out in a weird way that they want it to be to claim your health insurance, and they reject it, and they're making money on the float even if they know they ultimately, and a lot of people just stop pursuing it because it's too difficult, not worth it. With Medicaid, what is the agenda here, and does it change state to state? Like if you were to sort of categorize, we have some states who just want to drop their rolls as much as possible. We have others that are feeling, budgetary pinches and want to, reduce their rolls. We have other states that are just, they'll fulfill, they'll try and get as many people on there as possible. I mean, could you classify these states that way? And what is the benefit if it's a federal program? What's the benefit of a state to kick people off?
Well, I'll just answer that last one really quickly. It's jointly funded by the federal and state government, and especially in sort of poorer states, the federal government's paying a lot more, and the federal government increased its share during this emergency when it was asking states not to remove anyone from the rolls. But there is a state fiscal component, and that's why, the states that haven't expanded Medicaid yet under the ACA always say that they can't do it, even though study after study after study after study has shown that fiscally they would come out ahead. But there is a state component, and that's something that states will talk about when they talk about their interest in, doing this procedure more quickly relatively than more slowly. I think I would say two things. I would say, full stop, it's a huge logistical challenge for every single state. There's no playbook for this. There's really no precedent. We have maybe 15 or 18 million people are going to change their coverage status. And that's a volume that's on par with all the people that gained coverage during the Affordable Care Act. So, whether no matter what your sort of attitude about Medicaid is, it's a huge logistical challenge, and states are going to have to staff up and do all these things. And it's very, very difficult. That being said, I think it's also an opportunity for states to kind of, display their sort of persona about Medicaid. And, some states will act like the most important thing is to sort of get rid of the false positives, remove the people that are on the rolls but not eligible. Other states are going to act like the most important thing is to minimize like the false negatives, like churning people off who shouldn't be churned off, and will be like more emphasizing being more deliberative, taking longer, providing more messages. Other states, and I think maybe Arkansas has kind of distinguished itself in this way, has really publicized the fact that they want to do this as quickly as possible. And, like sort of when they talk about what the objectives are, the thing they'll say first is like maintain the integrity of the Medicaid program. And what they'll say second is, use resources to help the most vulnerable, et cetera. But I would say, one just thing to like, I think for no matter what anybody might say kind of posturally about that, it's a big accountability issue for governors. Like even in Arkansas, like a third of the population is on Medicaid. So I think that if a state is perceived as being reckless or sloppy, not doing a good job, and people are inappropriately disconnected from coverage, people that are getting treated for conditions or need medications, I mean, that's going to be an issue. So I think that even states that are making these kinds of comments, are probably also thinking that there's a lot at stake here, and they need to be careful.
I mean, maybe I'm jaded, but if I'm Sarah Huckabee, I'm Sanders. I'm excited to go to next year's CPAC and talk about how many people I kicked off of Medicaid. I mean, I may be a little jaded in that respect, but let me ask you this from a dollar perspective. Like, I mean, when we hear that we're kicking off that, and it depends on how it's executed by the states. So it could be anywhere from 10 to 15 million people. Maybe, I don't know how wide the window is, but that we're kicking people off of health insurance, right? This is Medicaid too. So it's not like there are, and maybe there are people who are making $100, $200, $300, $500,000 a year who are getting by, staying on Medicaid somehow. They're involved in this and they don't want to pay for health insurance. I'm sure somewhere in the country we could find an example of that. But broadly speaking, the idea that, it's somehow wasteful or fraudulent to have somebody who's making, $1,000 a year annually over whatever the depending on what the state is over the threshold, just seems just on its face to be just ridiculous. That we would uninsure these people because, like you say, that person's uninsured. If they get sick, they're going to go to the emergency room. The taxpayer is going to be paying 120% of what they would otherwise be paying, essentially, or whatever the figure is. They're going to be paying more. It's not even fiscally responsible. This is really more an ideological thing on some level, it seems to me. How much money is being saved here after you net out all the administrative costs associated with keeping people off, and then the projections as to how much they're going to cost, because 20% of the people you kick off are going to end up in the emergency room probably within the next month or something over the course of next year.
Well, let me say two things. I think you're absolutely right, is that the churn is just a dead weight loss. It's terrible for people. It's terrible for the state. It's terrible for the federal government. It's terrible for providers, because people are, constantly going on and off the program because of just bureaucratic snafus or just tiny little changes in their income. So I want to lay that out. But just to clarify on the bigger point, these 15 to 18 million people are not going to all become uninsured. Most estimates believe that more than half of them are actually either already enrolled in employer insurance or very soon will be. Like maybe their spouses has employer insurance and they're going to pick it up. We believe a lot of people don't even know that they're still enrolled in Medicaid. So it is bad, but it's not quite as bad as that sounds, because that would increase the uninsurance rate nationally by like 50%, but it's not that bad. But we do think that about 20% of these folks, maybe 3-4 million people nationally, will end up uninsured. So that, that's a terrible shame. And that's a huge problem, because we were at this, historic low with uninsurance thanks to this emergency measure. And it's going to depend on the way states behave and what state officials do to both not inappropriately terminate people and then also try to transition people to either the marketplace or CHIP, so that people that do lose eligibility for Medicaid don't end up uninsured. So the goal is to minimize inappropriate terminations and to maximize transitions for people that don't have ESI.
Okay, so if it is the case, only 3 or 4 million people, and only,
And that's a
are
lot
going
of
to,
people.
no, a lot of
That's
people
people.
are going to lose their health insurance because you have other people who could go on to secondary insurance, or they could go on to spouse, or they could get a job soon. And presumably if they have that insurance available to them, they're more likely to use that one because it probably has more access to providers than Medicaid generally does. In which case they're not costing the Medicaid system really anything while they're on it because they're not using it. So the expense to throw them off is actually more expensive than the use of their Medicaid. And then presuming that if there's churn and they fall back into it, then you need to administer them back into the program, creating more cost associated with that. But with that said, 3 or 4 million people without insurance, hopefully it's less, hopefully not more, but presuming 3 or 4 million people, then because the others it's not savings, right? For the federal government. I mean, if they're not really using Medicaid, and maybe there's some that are, but they could be using something else, I guess, and they would be carrying the expense. How much money do we know that is going to be saved?
Well, that's a great question. I mean, there are definitely people now that aren't really filing claims or using services. There's still sort of a contract in most states between the state and a managed care organization to care for people that are enrolled. And that, I think in many states, that contract has been adjusted to, kind of account for the fact that there are people that are enrolled but aren't really using services. And that's probably because they're enrolled somewhere else, and they're using services somewhere else. Some of them may not even remember that that at one point they were enrolled in Medicaid. I mean, that's really possible. But I mean, those are kind of non-problems, really, compared to people that either are eligible and fall between the cracks. And, we
Right.
know, for example, that the majority of people that are facing this, this bureaucratic nightmare don't even know about it. They're not even aware that this is happening. They're just out there kind of living their lives. They may not even know that the program, the health insurance that they have is called Medicaid. Every state calls these programs something different. And people are just famously uninterested in insurance. They don't want to think about their insurance. They don't want to switch car insurance. They don't want to switch health insurance. Like, they don't want to think about insurance. So these issues that are really consume so many people that think about health insurance all the time, the people that are most affected, I think a lot of them are going to be caught unawares, even though there's been a lot of effort to think about how to communicate with people. And that's one of the things that, everybody's really worried about, is people not getting messages, not responding, and then sort of falling through the cracks. And hopefully they'll find their way back to Medicaid. But, some of them will have important interruptions in care that will be consequential for them and, may not get back for a while. So that's something that everybody's super worried about.
Well, I'm sorry. I keep pressing on this point. I guess I'm trying to figure out, I mean, there's a statutory obligation, I guess, to kick these people off of Medicare. Is that it? Like, what's the rationale? I mean, Medicaid, I should say. What's the rationale for doing this? I'm trying, like, does anybody have a number? Is there anybody out there going like, it's going to save the U.S. government $100 billion this year? Or is it just, we're doing this because we're statutorily obligated. We have no option. I mean, what's the point?
Well, I mean, it's kind of a normal thing to routinely assess the eligibility of people for means tested programs. I mean, I don't think that's crazy. I think it's unfortunate how much the sort of status quo ante practice varied in states, and how like consumer unfriendly it often is, and how hard it is for people. We suspended all that during the pandemic, which I think was great because it boosted coverage. And now we're going to go back to the normal, which I sort of think I understand the reason for doing it, but the practice in which it takes place is often really puts people at a disadvantage, and people often lose coverage inadvertently. And that's just been this kind of cost that we've come to accept, churn and Medicaid, but it's sort of bad for everybody. So we're, kind of back to that again. But
I still don't understand. I mean, okay, I get that we're going back to normal. Normal was bad. We agree that normal was bad because of churn. I'm just curious, is like anybody out there going like, we need to get back to normal because we're going to save X or Y?
Well, I mean, we need to get back to normal because those are the rules of our sort of normal healthcare system, which I think a lot of people could say is, very fragmented, very complicated, very difficult for people, and leaves a lot of us uncovered. So I think if you said, gee, wouldn't it be great if we just had like one single system that was so much easier for people to participate in, then we wouldn't have all these problems to begin with, and we wouldn't have had to have erect all these measures during the pandemic, and then we wouldn't have to go back to the same system. I mean, I think that's like a very reasonable thing to say. And in fact, there's some states that are so kind of tired and sick of seeing these people like just making, a little bit too much for Medicaid and falling out and not having another option or not being able to afford going into the marketplace or whatever, that they've created things like basic health plans, or they've really double down on efforts to, like, say, for a population like kids, to like not redetermine their eligibility for long periods of time, to not interrupt coverage for people. So I do think that there are lots of people that sort of hate this aspect of the normal, where we redetermine people's eligibility, and we are often, either because they missed a message or because they have a slight change in their income, which is still very low, turning people out of their health insurance coverage, which nobody likes.
So how does North Carolina fit into this, right? I mean, they became the 40th state to expand.
Right.
I'm just curious about that particular set of circumstances into the larger Medicaid ecosystem here.
Well, I mean, it's great news, and estimated 600,000 people, I think, will gain coverage in North Carolina. That's one of the bigger states that hadn't expanded. Obviously, Texas, Florida, Georgia, other really big states where there are a lot of people in the so-called coverage gap, which is one of the sort of cruelest things about our healthcare system, where there are people who are too poor for the marketplace, so they're not allowed to go to the marketplace, but then they have no other option, and their option is to be uninsured until these states expand Medicaid, which is something that would just be wonderful if all the states would do. So it's great news that North Carolina is expanding Medicaid, and we certainly would love to see the other states make the same decision. How does it affect the unwinding issue? I mean, it's going to take place a little bit later. It's kind of separate. I think, in the expansion states, thinking again about kind of the metaphor of the front door and the back door, in the expansion states, the front door is a little bigger because there are more ways that people can be eligible for Medicaid. So, the back door might be a little bigger too when it opens, and we might see sort of more disenrollment of low-income adults in expansion states in general, but they're more likely to have someplace to go because those states, employers make more offers. And, I think that, like New York, for example, has a basic health plan, and there's more options for adults. I think in the non-expansion states, we're going to see a little bit less of that because fewer of those folks are eligible to begin with because they haven't expanded Medicaid, and we're going to see a lot of children, and most of those children should be eligible for CHIP. But there is a concern that even some kids could fall through the cracks if there's not sufficient outreach.
3 to 4 million you anticipate will be out of insurance after all of this is said and done. How many children? I would imagine much less, because there are CHIP programs that sort of like catch them when they fall out of this Medicaid expansion.
Yeah, I think the child uninsurance rate now is something like 3.7%, which is super low, and that's something that is a big achievement. And I think there's always going to be a prioritization for keeping children covered. And even in states that haven't expanded Medicaid to low-income adults, they have CHIP programs with reasonable eligibility. So there's certainly a hope that we're not going to see a lot of children lose coverage. But I mean, I don't think it's crazy to think that some will. And there's certainly linkages between children's coverage and adults coverage. So when adults lose coverage, sometimes we see kids lose coverage, and parents and children, and sort of the reverse can be the same. So I think that it's certainly a concern, but there is the CHIP mechanism, which is helpful for kids.
Kathy Hempstead, Senior Policy Advisor at the Robert Wood Johnson Foundation. this conversation would have been so much easier if we just had some form of Medicaid for all or Medicare for all. We wouldn't have had anything
We
to talk
wouldn't
about.
have the conversation, you know? I mean,
No.
I think that the public health emergency there's things about it that weren't equity promoting, but I think the flexibilities around health insurance were things that really did promote more equity and give more people access to healthcare and coverage. And now, unfortunately, we're about to kind of erect all of the barriers to that we had before the pandemic.
I could only imagine if we had folks from, European listeners listening to this conversation, just completely bewildered that we can be sitting here going like, good news is only 4% of our children don't have health insurance. I mean, it's nuts, but thank you so much for walking us through it.
Sure. Thanks for having me.
Thank you.